So this is kind of after the fact. So we planned this activity a couple of months ago when it was still unclear if the measles outbreak is over or not. Since then it has been declared over by the New York City Department of Health. But I guess these things happen over and over again, so I think it's still very important, timely to do this short update. I was trying to make it fairly practical and hands-on, and also give a bit of just an historical perspective on this. And so first of all of you know that the measles vaccine has been around for a very long time, and it's actually one of the earliest vaccines that have been used pretty universally and has been extremely successful. And just to show you, the massive number of cases before the vaccine was introduced, and then you still see little blips here and there. And I just want to point out this one here. This blip was due to children not being able to get vaccines for cost reasons, no insurance, and actually vaccines for children was introduced at that time to kind of address that issue. Children not being able to get vaccines because they don't have insurance, or their parents don't have insurance. So vaccines for children actually really brought that number of cases down permanently a lot until this happened, and this is where everybody got pretty upset and nervous about what could be going on. And I'm not going to give you that much background on the outbreak, because you've all had other educational sessions, you've read the papers, you've seen the news. So this, of course, is something that the epidemiologists and the public health departments get very anxious about, and this is what was going on in New York. So 2018, 2019, so a big increase in numbers. But what I want you to see and appreciate is that there's always been cases, and what was different though is that most of the cases before, where do you think they came from?
Abroad.
Mostly imported. So, but what was a little bit different this time was that there's actually been, I picked the wrong slide, so this is, okay, that's embarrassing. So I picked the older slide. There's an updated one that carries through 2019, and the website was a little hard to navigate. So what I would have shown you is that actually the percentage of imported cases actually did go up, did go down, and the percentage of cases which originated in the U.S. actually went up. So this prolonged outbreak with secondary cases in the U.S. that originated here, that is the big concern. And of course, along with that, the immunization rates. So we are talking about pockets of people who did not get the high immunization rates that we need. And this again is not unprecedented. And I wanted to show you, this is again a historical perspective, what happened in England when in 1998, about this time, the Wakefield paper was published, and it was a public health disaster in England in particular. And this is before it kind of got exported and transported to other countries worldwide, which of course is now more of a global phenomenon. But in England it was a big public health disaster. You could see that immunization rates were above 91%, which is where you want them to ensure herd immunity in the population. And then it was basically going down, down, down. Even years after, this I think was put out in 2008, the vaccination rates in England overall and in London in particular were really low, and they're still not quite where they should be. So many of the cases imported to the US were actually cases from Europe, so England, Germany, Switzerland, Italy. All of these are countries that are affected by a belief system that immunizations can be harmful, and this is ultimately what has led to a lot of the outbreaks we've seen in recent years. And of course, the secondary infections, which I pointed out earlier, are so important because that indicates that, and it also shows you how transmissible and infectious measles are. And this is pretty the big concern. So this famous slide shows that 9 out of 10 people who are in the vicinity of somebody who has measles will come down with measles if they're not immune. And so it is one of the most contagious illnesses that we know, and the most contagious viral illness. I guess smallpox is eradicated, but measles is, I'm not even sure if it's as contagious as measles, I think it's less. But measles is spread via the airborne route, so that means you need to be knowledgeable about the precautions, and we'll talk about that a little bit more. And what's important too is that you have this 2-hour time period where measles just lingers in the air as airborne and can be inhaled by anybody who walks into that area up to 2 hours later. And then, of course, the time is important, and those are public health definitions, and I'll show you another slide where that has implications for prevention and testing as well. So it is infectious 4 days before the rash appears and 4 days after. And so all of this means you have to be on top of the recognition. And so if you recognize early, you can implement precautions early. And that means you protect all the other people in the building, all the sick patients that, or all the immunocompromised patients that may not be sick yet, but could become very sick and die if they get infected with measles. Apply clinical case definition is kind of a first step. You have the fever plus maculopapular rash plus one of the 3 C's. And what are the 3 C's? They are listed here. Because it's a respiratory virus, it will infect the conjunctiva, it will infect the nasal mucosa, as well as the lower respiratory tract. So any one of those 3 C's would fulfill the case definition. Most patients will have all the 3 C's. Measles is a very aggressive respiratory virus if you have the full-blown picture. We have the pictures and the posters outside in the building. They say fever and a rash. They don't talk about the 3 C's. Why do we not put it there? Well, because it's a little bit hard to differentiate. It's for the public for the most part. We want people to self-identify. We want people to say, oh, my child has a fever and a rash. Let me see if I can tell someone right away. And that's kind of in the old days, and I was trying to get a picture of this, but I couldn't find it. Old children's hospitals had an entrance where there was a greeter. On the left-hand side, people went that didn't have a fever and a rash. On the right-hand side, children with fever and a rash went. So basically, at the door, there was a separation. You had a separate area where they could be evaluated quickly. Somebody could take a look at the rash, could say, oh, this looks like chickenpox, or this looks just like enterovirus, and they could be cohorted or separated. So we don't have that anymore, even though that was an idea that was resurrected for things like pandemic flu and SARS and other things. And it's, I guess, just for logistical reasons and resource reasons not possible. But the idea is still, you see the patient hopefully self-identify with fever and rash. You then pull them to the side. Some public health authorities say, keep them outside. So I guess that's again not very practical in most buildings, but I guess if you're in a doctor's office, you don't have good isolation facilities, somebody's not dying on your doorstep, you could go outside and meet them there and take a look and figure out what's going on and see how can they be evaluated safely without endangering others. At minimum, get them into a private room, possibly ideally with airborne precautions if that's available. So you look for these things. That's the first step. Anybody with a fever and a rash, and then if you find the classical clinical findings, then of course you have your diagnosis of measles, and based on the appearance. You don't always see that initially. Sometimes you just have a fever and a rash right away, or you may just have a non-specific prodrome. In which case you also have to look at the epidemiologic thing. Is this a patient who comes from an area where there have been cases of measles, where there could have been exposure, any contact with somebody who has traveled to an area where there's been epidemiologic exposure? Because remember, people can be infectious 4 days before the rash appears. So there could have been an adult traveling somewhere who comes back, has a fever, and then would infect the child even before it's recognized as measles. The next step would be, once you suspect, based on epidemiology or based on the clinical findings, that this is measles or have a high index of suspicion, you have to contact the public health authorities. And here at Downstate, and I believe at Kings County, it should have been a similar process. The testing would be done by the public health lab. So the system that was set up was a somebody would come, pick up the samples, and the OH would also give you instructions on how to collect the samples. And we had material in the ER package that would give instructions just in time as well. So the confirmation by diagnostic testing would then be implemented. If you are in an outbreak situation, if you see patients with clear findings and clear exposure history, it's not actually recommended to do the diagnostic testing because you can make your diagnosis that way. Now here at Downstate, we didn't really have a lot of cases. We had some suspected cases, and so in that setting where it's not so clear how good is the epidemiologic link, are the findings typical, the testing would become much more important. But I know that in Rockland County, at some point they stopped doing the testing because they would just go by the clinical case definition. So the preventive measures I started mentioning would be to identify anybody who's been exposed and then implement the vaccination prevention depending on the immune status of the patient. I'm not going to spend much time with this, but I wanted to go through how, when you see that patient in front of you, how do you make sure you're making the correct diagnosis? How do you make sure you don't miss measles, but also how do you make sure you don't overdiagnose measles? Because, like I mentioned, the resources are something that you have to have. In the hospital setting, you have to implement airborne precautions. Now, if you were to take a guess, how many airborne isolation rooms do we have in the hospital?
4.
I think that's accurate. It's one in the E. It's two in the E, right? Yeah. So, and then we have those upstairs. We have on 7 we have 2, and then we have 1 in pediatrics. That's new. So it's fairly limited, and especially if you have a pediatric patient where there's less than for adult patients, then you can't put everybody with a rash and a fever into airborne isolation because you might be running out of airborne isolation rooms very quickly. So you do have to try to identify, in addition to fever and rash, which that's what the public knows, but you're a doctor, so you have to know more than just fever and rash. So you have to identify what else is going on that could tell you this is measles. And I think I have a later slide about the timeline, but this is just to show some representative images that all of you have seen before, but I just want to again point out that the complex spots are notoriously hard to detect. They only appear for a short period of time, and they can take different shapes and size and different numbers. I've never seen this. The best I've seen is something that resembles this. This is an NHS teaching slide, so somebody must have come with these really impressive complex spots. But it could be as subtle as this or this. And then, of course, the rash is characteristic. Raised maculopapular, blotchy, and the distribution is important. So it starts perioral face, upper trunk, and then it spreads. It can spread to the feet and hands later in the course. But again, the conjunctivitis is obvious in both of these patients. The coryza isn't as impressive. The cough is almost always there. So the 3 C's. And this would be the sequence of events. So you have the incubation period, and that's really long for measles. So in terms of looking for exposure, you do have to remember that time frame, the travel history, the exposure to travelers. And then the initial symptoms would just be fever and malaise, and that's before everything else happens. So you have the fever and malaise, you have a better one, so distant transport as well. So you have the fever, you have the 3 C's, and then you have the exanthem subsequently. And the exact timeline is something more like this. So at time 0, you start to identify the patient as a potential measles case with fever and malaise at 0. And then within about 12 hours, you get to see conjunctivitis if it's present, cough, coryza, and then the complex spots. So all of these happen before the rash, but you have to look for all of these and remember that if you see somebody with conjunctivitis, they may not have the complex spots yet, and then obviously the rash would be later. There's a bit of the range of time could be a little bit longer. This is the minimum time of the time range, but what's important is that this is about 36 hours, and then it takes about another 36 hours before we see the rash. So when you take the history, what's important is that the IgM assay, which is the most widely used and I guess the oldest assay we use to confirm, not the oldest, but it's I guess the one that's most easily available and has been used for the longest time. This IgM assay, it doesn't become positive until, it says here, about day 3 after the rash appears. So if you do one initially, early on, it might be negative, it might be a false negative. This test was done, we don't have it here at Downstate, I'm not sure, I think Kings County sends to North Shore, so Northwell, so they may actually give you a good turnaround time for that. But again, it's of limited value in the very acute setting. So here you need either viral culture or you need RT-PCR. Viral culture is almost never done anymore, but you do have PCR availability, and that will be positive, very high sensitivity, even on the first day of rash. So again, this is very important, very practical. But you do get sample collection. You can always do serial titers. You can do an IgG early, do an IgG in 4 weeks if anybody has any doubt about something being measles or not. And then, of course, the complications, the clinical course is more protracted. So once you identify the patient may still develop clinical complications later on, and that's where you need the follow-up. Okay, so here's some other points about when should you really think about measles, and the first one is in anybody who's not immunized, and that would be the biggest risk factor. And I showed you the slide earlier where in England an immunization rate of over 90% was the one that's really protective of the population. That also implies that some people, even though you may have high immunization rates, you could still it's still possible to get cases. And how does that work? So the vaccine is not 100% effective. So even if you vaccinate over 90% of the population, some of the ones that are vaccinated will drop the antibody positivity rate if you were to do a study below 90%. So your herd immunity actually probably is more around, is there when about 85% have antibodies. So the first dose is 93% effective, but 2 doses will lead to 97% effectiveness. That's why at 1 year of age we give 1 dose of measles vaccine, and then at 4 years of age we give a second. And it's not a booster. The second dose is really given just to cause immunity in all those who never responded to the first dose. And that's been well studied. Even if you give a first dose and then you give a second dose a couple of months later, it does not lead to more to boosting of antibodies. Why do we think at 1 year some people do not respond? So it has to do with the returning antibodies. So there may still be, even though it's late, but at 12 months there may still be some interference with returning antibodies. And that's the reason why we don't vaccinate before 12 months. So at 12 months is kind of a golden middle between protecting infants early and toddlers early, but still getting good vaccination rates, even in the presence of some lingering maternal antibodies. And that's been shown because in populations where you have a lot of measles disease, mothers have high levels of antibody. There's actually poorer responses to vaccinations. When you counsel somebody about upcoming travel who has a 7-month-old infant, what do you recommend if it's international travel?
So they get 1 dose before they go, they're under 12 months, and then they have to redo the series starting at 12 months.
Right, exactly. And that's been a very important message, even though the vaccination response rate will be low, but for the ones who do respond, it will actually protect them. And then you give the regular dose, you still have to give the 2 doses. So the other risk factors are, that's why we always ask about travel. It should be a routine question. And the 21 days is based on the upper range of the incubation period, which tends to be shorter, but 21 days is the upper range. And then there is contact to a community with measles outbreak, and that becomes like an added risk factor. This could be within the US, could be in populations where immunization rates are very low, and I think the distribution of the outbreak in this past year showed that the pockets were most in New York, there were some on the West Coast, and the public health authorities were able to link that to low immunization rates in those communities. And the cases that did happen in children and adults who did not have antibodies or did not have a history of immunization. And then, of course, the classic illness findings. If you find all the classic ones that I showed earlier, then again, you would suspect measles, even if it's outside of that classic epidemiologic link. But in that case, you would want to do the diagnostic testing because you don't have the high-risk exposure. So again, this is something I mentioned before. Try to keep the patient. Don't tell them if you get the call. I have somebody with fever and rash. Don't necessarily tell them to sit in the waiting room and come to the hospital. And when my patients call me, I usually try to do some phone triage before I tell them to where they should be seen, and that would avoid a lot of headaches down the line. When they do come and they are at your doorstep and they stand in the waiting room and the clerk or a nurse identifies this as a patient who could have measles, then you should meet them. Again, the N95 is important to protect yourself. You should place a face mask on the patient because that's how the virus is transmitted. It's the patient coughing, sneezing, and that will disperse the droplets, so you can decrease infectivity that way. And then the private room would be the first step if an airborne isolation room is not available. Obviously, that would be ideal. And then you have to remember the room has to be blocked. In the hospital, these things become fairly routine because we have good training on all ends for the most part. But if you ever work in a setting where these routines are not clearly established, or it's been a couple of years since the last outbreak, well, then maybe sometimes people forget all the education hasn't been happening on a regular basis, and then you have to remember yourself and instruct people. And then, of course, you need to collect information on everybody who's been in the building at the time or in the vicinity and follow up on. So this was not very long because it really was supposed to serve as a refresher because all of you had a lot of education, and I think at this point we don't see a lot of cases anymore, but I think we have to be on the lookout for measles as well as other contagious illnesses, so it has to become a habit of asking those important questions about epidemiology. And I think we have plenty of time for questions.
Vaccines are, so it's a combination vaccine.
Yeah, so in the US we only have MMR, and other countries have individual components. There is a single measles vaccine, there's a measles rubella vaccine, so there are different products on the market. But in the US, a decision was made to use only the MMR, so the American College of Immunization Practices endorsed that, for the reason that it just improves vaccination rates. Because if you have to get people in for single dose vaccines, then especially with reluctant, hesitant parents, you never get everybody fully immunized, and that's been shown a lot. But
In Europe, they don't use the MMR.
so it depends on the country. So in England it's MMR, and in the US you could probably order the other vaccine and then give it. In the UK, where let's say it's all public money, the public money does not support getting single-dose vaccines, and that's a big concern because a lot of parents are opposed to combination vaccines. So then they request the individual vaccines, and when I was working there, I could not do that. I would have to buy it and import it pretty much if they wanted that. Sometimes you do have to negotiate and make some concessions. If you want if somebody's willing to immunize their child with single-dose vaccines, I'd be the first one to say, okay, then let's do that. It's better than not giving anything, but there's logistical and cost issues. Yeah.
When do you give the measles IV?
Yeah, so you give that to people who are immunocompromised, who cannot get the live attenuated vaccine. So those who have a high risk of getting disseminated infection complications with the live vaccine, you would give the immunoglobulin, and that has to be given within 72 hours. So
if you diagnose someone with measles and they have home, you would give the IG?
So you have to,
It's all the cons,
you do it, it's for the content. So you want to prevent, this is secondary prevention. You want to prevent cases in those who don't. So when you have a waiting room full of people that have been exposed, you have to go around, you have to collect all the information on the people who were in the building. And then that goes to, in the hospital, like I said, would go to infection control, and then you have the Department of Health that would assist with preventing these secondary cases. And so the Department of Health was very busy trying to set up distribution points and trying to get the additional vaccine and immunoglobulin to practitioners who saw a lot of these secondary exposures.
Can you speak to the American Samoa outbreak and lessons learned?
The Samoa outbreak?
Yeah.
Oh, you know, I just saw the headlines, to be honest with you, so I could not, I don't think I can comment. Yeah.
So,
What?
that, would you give measles immunoglobulin to
Yeah, in pregnancy, the live vaccine is not as contraindicated. Yeah, and so anytime that you have an outbreak situation, there's always very specific guidelines that are put out by the Department of Health, and it's important to stick to these. They have very good scripts, and again, the Department of Health provide a hotline that addresses any sort of contagious illness that would also address any measles questions. So because we don't see this a lot, and even if we do see a few cases, we still have some extra, some unusual situations, scenarios, and I think it's very important for these kind of infections to always refer to what the public health authorities tell us. And yes, they want to know what the cases that we see on their end, so they can do their epidemiologic curves and all that. But I think it's also a resource for us that we can get some real-time input, and that may be much better than what you get even from infectious disease consultants, because they get all the questions from all the practitioners in the city, so they're very aware of any sort of unusual scenarios, and they have their consultants that can also give them some more input. So I call them myself all the time for measles scenarios and anything else. So it's good to use what you have. It's a great resource. More questions? Okay, I guess it's an early lunch.
It's the end of the day. Survive 2 minutes.